It looks like we're good to go, Dr. Deik.
All right, let's do it old-fashioned style. Sorry.
So much for technology.
Yeah.
Glad you were here, so thank you.
Sure, I'll keep my camera off so that the video quality doesn't deteriorate, but I'll turn on my camera when we're ready for the Q&A.
Perfect.
Let's
Okay.
just do it like this. So good morning, everybody. Sorry about those technical difficulties there. My name is Dr. Andres Deik. I'm a neurologist at the University of Pennsylvania. I'm a movement disorder specialist, and I run the Comprehensive Parkinsonism Evaluation Clinic, which is a multidisciplinary clinic for patients with atypical forms of Parkinson's, including MSA. Today, I'm going to give you an overview of MSA and its management. It's about an hour long, so hopefully you'll find this information informative. Here are my financial disclosures. The only thing that's relevant is that we will be launching the Lundbeck trial for MSA, and I am the site PI for that here at Penn. And here's an outline of what I will be discussing. First, we'll go into some definitions about what Parkinsonism and MSA are. Then we'll talk about the symptoms that we treat in MSA, both the motor and non-motor symptoms. We'll talk a little bit about multidisciplinary care that is offered at Penn. Then we'll delve into the clinical trials that have recently been published, as well as upcoming. And then finally, we'll sum up and close, and then we'll make room for the Q&A session where you guys can just fire away whatever's on your mind. All right, so let's start about talking about Parkinsonism and MSA. I have a very frequent question from my patients, which is, what is Parkinsonism? And there's always this confusion about, well, what is Parkinsonism? What is Parkinson's? How are they similar? How are they different? And what I would say is that Parkinsonism is a broad term, which I'd like to think about as an umbrella term, under which different other conditions fall. One of them, of course, is Parkinson's disease, and Parkinson's disease is the most frequent form of Parkinsonism. But there are also the atypical Parkinsonian syndromes, which also fall under the Parkinsonism spectrum. And I think spectrum is kind of a key word here. Parkinsonism really refers to anybody that has symptoms of Parkinson's disease, whether they actually have Parkinson's or not. Turns out there are many different conditions that can give patients symptoms of Parkinson's, and they're not always necessarily Parkinson's disease. Within the atypical Parkinsonian syndromes, there are a number of subdivisions. There is PSP, that stands for progressive supranuclear palsy. There is CBD, which stands for corticobasal degeneration, or more recently, now named corticobasal syndrome, Lewy body dementia, and multiple systems atrophy. Those are the four core atypical Parkinsonian syndromes. And what defines Parkinsonism is the presence of slowness. So when patients have slowness that is due to a neurologic disorder, we think of them as Parkinsonian, and that is the core feature to make a diagnosis of Parkinsonism in a patient. Now, you cannot just have slowness. You have to have slowness and other symptoms to try to make a definitive diagnosis. So in the case of Parkinson's disease, for example, you need to have slowness in addition to stiffness, tremor, or imbalance. So the presence of slowness and any of these other symptoms is enough to make a diagnosis of Parkinson's disease. However, to make another diagnosis of one of the atypical Parkinsonian syndromes, along with all of the symptoms of Parkinson's, you also have to have specific features that are characteristic for each of the different types of Parkinsonian syndromes. So in patients with PSP, those folks usually have eye movement abnormalities. So they usually cannot look up or down, particularly down. And that is sort of the hallmark of this condition. In corticobasal degeneration, you have to have a condition called apraxia, which is this difficulty doing tasks that you once were able to do just because you, in a way, sort of forget how to do them. The symptoms are also quite asymmetric, where one side of the body is severely affected while the other side of the body may be virtually normal. Lewy body dementia is characterized by the presence of cognitive decline, and it is that cognitive decline happening early in the course of the disease that makes the distinctions between Lewy body and Parkinson's. And in multiple systems atrophy, it's the presence of dysfunction of a part of the nervous system that we call the autonomic nervous system. The autonomic nervous system is the part of this nervous system that is in charge of all of the involuntary functions of the body. Things like regulation of the heartbeat, the blood pressure, bladder control, bowel function. All of that is under unconscious or subconscious control, and it is all controlled by the autonomic nervous system. Key features in patients with multiple systems atrophy are changes in the way the body regulates blood pressure and bladder control. So in a patient who has prominent signs of autonomic dysfunction, along with symptoms of Parkinson's, we usually confidently can make a diagnosis of possible or probable multiple systems atrophy. Now, something that happens often is that these characteristic features of multiple systems atrophy or any of the other atypical Parkinsonian syndromes for that matter, are not present at the beginning. When the patients first come to our office, they might only have enough symptoms to make a diagnosis of Parkinson's disease. However, we follow patients over time, and as we follow them, we notice that other symptoms emerge that then sort of point us to the direction of a diagnosis of multiple systems atrophy. So it's not uncommon for many patients with Parkinson's disease, many patients with multiple systems atrophy, to initially be diagnosed as having Parkinson's disease. And then as the disease progresses and as we follow them over time, we reevaluate that diagnosis and we make a more accurate diagnosis of MSA. Now, how does Parkinsonism come about? Why do patients develop these symptoms? Parkinsonism is basically a reflection of the drop in a chemical in the brain that is called dopamine. Dopamine is a neurochemical that is involved in the functions of the brain that allow patients to move. And for reasons that are incompletely understood in patients both with Parkinson's, but also with other Parkinsonian syndromes, there is a loss in the cells that produce dopamine. And as these cells are being lost, the sort of net number or amount of dopamine in the brain starts to reduce. And with the reduction in the dopamine levels comes Parkinsonism, particularly the slowness. So a way of thinking about it is the more dopamine you have, the more you move. The less dopamine you have, the less you can move. Now, what leads to this drop in cells that produce dopamine is something that I will discuss next. If we think about MSA in particular, we think of it as a rare condition. It's about 2 to 5 per 100,000 people in comparison to Parkinson's disease, which is present in about 1 to 2 per 1,000. So you can see how much more rare MSA is compared to PD. And we think it is due to toxic accumulations of a protein called alpha-synuclein in glial cells. In the brain, there are 2 types of cells. There are the neurons, which are the nerve cells, and they are the main cells in the brain that allow people to function and the brain to function. You know, these are the cells that have the electrical activity. But there are also glial cells, and glial cells are the cells that allow the neurons to live. So in a way, they're like support cells, if you may. And there's also all different subtypes. And the pathology in MSA has been found to be in these glial cells in a number of different ways. Alpha-synuclein is a protein that normally is involved in the transmission of signals throughout the neurons, but also in the formation of energy. So there is a part of the cells called the mitochondria, which is like the organelle of the cells that is in charge of creating the energy that cells need to fulfill all of their metabolic activities. And in patients in whom alpha-synuclein starts to accumulate, what we see is a number of dysfunction in different types of organelles. So the mitochondria start to fail, and there is a loss in the ability to produce the energy that the cell needs to live. But there also seems to be a clogging, if you may, of the waste disposal system of the cell, and the cell is no longer able to get rid of toxins and other substances that interfere with cell function. The net effect of all of these changes is that patients who, hold on one second. There we go. The patients who have accumulation of these toxic proteins will then lead to the onset of multiple systems atrophy. Now, there are symptoms that help us distinguish MSA from Parkinson's disease. I think hopefully you guys can see there's a video on the right side of the screen. I hope it's playing okay. With a patient who has this sort of little twitching of the fingers. This is called polymini myoclonus. It's one of the signs of MSA that we see. It's not something that we expect to see in patients with Parkinson's disease. And this is just one of the features. The other feature you will see here, which is ataxia, and it's this inability to reach a target in a coordinated fashion. You see as this patient is trying to touch my finger, and as she reaches my finger and goes back to her chin, she's not quite on target. It's a little bit off. This is called ataxia, and it's another sign of MSA that we do not see in Parkinson's disease. As I mentioned previously, autonomic failure, meaning dysfunction of the autonomic system manifesting as changes in blood pressure control and bladder function particularly, are high risk or sort of important red flags to suggest that patients may have MSA and not PD. But if we think about the motor symptoms, there's also other signs that point toward MSA. The onset of balance changes and fall, particularly early onset. Patients with Parkinson's do have changes in balance and falls, but that is something that is expected to happen to them much later in the course of the disease. The early onset of difficulty swallowing and speaking is also a prominent sign in MSA that we don't see in Parkinson's. People have slurred speech, oftentimes also relatively early, and that can also help us distinguish. The response to levodopa. So in patients with Parkinson's disease, the response to levodopa is very predictable. We know that if we give them carbidopa-levodopa, which is the sort of standard of care of the management of Parkinson's, we know that their symptoms are going to improve. However, in patients with MSA, it's a little bit less predictable. Some patients improve and some patients do not. In fact, some patients feel worse on this medication. So that can also help us distinguish between the two. Among the people who do respond to carbidopa-levodopa, though, some of them develop dyskinesias, which are sort of involuntary extra movements. And these are usually restricted to the upper half of the body, particularly the neck and the lower face, as opposed to patients with Parkinson's disease in whom the dyskinesias are usually below the neck. They also can develop truncal dystonia. Some patients tilt to the side, other patients tilt forward quite significantly. The polymini myoclonus that I showed you in the video, that little twitchy, jerky tremor in the fingers. And then something else we see in MSA that we don't see as much in Parkinson's disease is anterocollis. There's a picture here at the bottom of your screen on the left side, of the left-hand side, of this gentleman whose chin is sort of tucked into the chest. It's really the pulling forward of the neck, what you're seeing there, which is not something that we typically see in Parkinson's disease. When in doubt, there is a scan called a DAT scan, which is a type of nuclear medicine scan that can help distinguish whether somebody has some form of Parkinson's versus no Parkinson's at all. Sometimes we see patients with symptoms that are perhaps suggestive of Parkinson's or one of the atypical Parkinsonian syndromes, but sometimes we're not quite sure. And then we use this test. The test does not distinguish between Parkinson's or any of the atypical syndromes, including MSA. All it can tell us is whether somebody has some form of Parkinson's or they do not, which can be helpful for us sometimes. Sometimes we really cannot tell just based on the examination. And that is usually true for patients who are quite elderly, particularly over the age of 85, who might slow down for other reasons, orthopedic reasons, pain reasons, but then they have slowness, and it's hard for us to distinguish whether this slowness is due to their age and other comorbidities, other medical problems, or whether it is because they're developing some sort of Parkinsonian syndrome. A caveat about DAT scan, patients who take antidepressants would need to stop the antidepressant before they can have the DAT scan. The antidepressants actually interfere with the read of the DAT scan. There's a list here, as you can see, of all the substances that interfere with the DAT scan, as well as the amount of days that they have to be off those substances before they can undergo the DAT scan and have reliable results. So this is something that for us is very relevant, since I would say over 90% of our patients take some form of antidepressant. So it often does limit how much we can use this technology, but as you can see, most of them only have to be off for about a week or less. With some rare exceptions, I would say the big one here is fluoxetine, that's Prozac. That one has to be off for 45 days. And sometimes patients just cannot tolerate being off Prozac for 45 days. So those would be folks in which we would not order this kind of test. Another test that we usually order in patients with MSA, and really for all Parkinsonian syndromes, is a brain MRI. So you can see here at the bottom of your screen, different sequences, MRI sequences, as well as different cuts through the brain. And what it's showing is different changes that we see in the brain MRI. So if you can see the images that are labeled A and B, there's white little arrows there pointing at this structure that is called the basal ganglia. The basal ganglia, we think, is one of the structures that is involved in MSA, and we can see changes in the structure there. Particularly if you look at closely at image B, and I hope this is playing okay on your end, you'll see these little black streaks where the white arrows are. Those are abnormal. Those should not be there. And it tells us that there's been changes in this area of the brain called the basal ganglia. If you look at images C and D now, you'll see that the arrows are pointing to another structure in the brain that's called, especially in figure C, that is called the cerebellum. The cerebellum is the area of the brain that coordinates movement. And what we see is shrinkage of the cerebellum. If you now, so those white arrows are pointing at that. And if you look at figure E, the arrow within figure E on the right side of the image is also pointing towards shrinkage of that same structure called the cerebellum. It's a different cut. Here we're looking at the patient from the side, whereas in figures C and D, we're looking at the patient from sort of top to down. And then a final finding, if you look at figures D and E, is this sign called the hot cross bun sign, where the arrow, particularly in figure D, is pointing at this little cross-like structure that resembles a hot cross bun, which is sort of a type of bread that is giving over around Easter. It also happens that this area here shrinks, and that's what you can see in figure E. The arrow on the left side is pointing at that same structure, but again, from a different angle. Now, all of these changes can be present at once. They can also be some of them present and not the others. And it is also possible that we do an MRI in a patient and the MRI is completely normal, particularly if we do the MRI early in the course of the disease. So it doesn't always help you. Like if it's not there, it doesn't rule out the disease. But if it is there, it helps us in the context of the medical examination. It helps us to sort of be a little bit more confident about our diagnosis. As you can see also from this slide, the onset of MSA is around age 55, but there's a broad range there, as you can see. A little bit more prevalent in men, but not a lot. And then we already spoke about the different areas in the brain that are affected. Now, depending on which areas of the brain are affected, we think of two different types of MSA. MSA-P, which P stands for Parkinsonism, is a type of MSA where patients have many symptoms that make it very similar to Parkinson's disease. We like to think about it as sort of a Parkinson's disease with very pronounced autonomic dysfunction. And the pathology there is back to images A and B, mostly related to changes in the basal ganglia. Whereas with MSA-C, which C stands for cerebellum, the pathology there is in the cerebellum, which is this yellow structure here that you can see on the circle on the right side. And changes in the cerebellum, since as I mentioned before, the cerebellum is involved in coordination of movement, will cause patients to have a lot of clumsiness in the hands, as well as slurred speech and balance issues. Now let's switch gears a little bit and talk about the treatable symptoms of MSA, and we'll start with the motor symptoms of MSA. So slowness and stiffness in MSA can be treatable. We treat that just like we would treat slowness and stiffness in Parkinson's disease. The gold standard of treatment is levodopa. or carbidopa-levodopa, as some of you might have heard it before. The levodopa is the active ingredient in carbidopa-levodopa. The carbidopa part really just prevents nausea. It's available in a different number of presentations, including extended release formulations and also on-demand formulations. This compound called Imbresia, which is an inhaler that helps with wearing off. Now, as I mentioned before, not every patient with MSA will improve with levodopa. We often try it in most of our patients, but it's a little bit difficult to predict who's going to be helped by this and who's not. So we basically offer it to everybody. Side effects to think about or be in the lookout for includes fogginess, sleepiness. It can also worsen drops in blood pressure that patients with MSA already have. It can cause confusion for some patients, hallucinations, seeing things that are not there, and then dyskinesias, which are these extra movements that I mentioned. If you think about Michael J. Fox, and if you've seen him in interviews, how he kind of wiggles and squirms in a chair, those are dyskinesias. It's a side effect of the use of levodopa. Tremor and dystonia are other symptoms that we see in MSA. Dystonia relates to these abnormal postures that people with MSA can adopt. You can see two examples here. The example here on the top is a patient with hand dystonia, where the fingers are curled and it's very difficult for them to open their hand. Whereas in the bottom there, you have a patient who has developed dystonia of the feet, and the feet can turn in and the toes can curl. Sometimes these symptoms respond to levodopa, not always. When they don't, there's other alternatives. There is a medication called Artane or trihexyphenidyl, which can be helpful in treating dystonia. However, it can cause dry eyes, dry mouth, constipation. It can also cause urinary retention, so the inability to empty the bladder, which oftentimes is a problem in people with MSA. So I can't say that we use it a lot. I would say we use it more in patients with Parkinson's than we do in patients with MSA. Amantadine is another medication that we use in patients with tremor and dystonia. It has a similar mechanism of action than Artane. However, it is a little bit better tolerated. It also comes in short-acting and long-acting formulations. The long-acting don't have generics to them, so they tend to be quite expensive and not covered by Medicare, unfortunately, because they are superior than the short-acting versions. However, the short-acting version, Symmetrel, which is the trade name, is also a very effective drug. And then when everything else fails, there are botulinum toxin injections. There's 4 brands available commercially in the US, all of which can help relieve the symptoms of dystonia. The injections work for about 3 months. The patients have to come and get re-injected every 3 months. But the nice thing about botulinum toxin injections is that it's local therapy. It weakens the muscles that you inject, but it doesn't really spread elsewhere in the body, so you don't have to deal with side effects like you would with on any of the oral medications. Now, patients with MSA who have gait dysfunction and falls can be tricky to managing. And I think the most important part when a patient comes to us and tells us that they're falling is for us to try to understand why it is that they're having trouble walking and falling. Because there can be many different reasons, and all of them are treated differently. The big one, and I would say perhaps the most important one in patients with MSA, is drops in blood pressure. That's called orthostatic hypotension. So people just feel lightheaded when they stand and then they collapse. Sometimes they pass out. There's different ways of treating that, which I will mention later in this talk, but just to give you sort of an advancement here, we encourage hydration, lots of water, sometimes salt in the diet. The use of compression stockings or abdominal binders can be helpful, and then there's a number of different medications that can artificially raise the blood pressure, which, as I said, I'll mention later. Sometimes it's the Parkinson's symptoms. Sometimes it's just the stiffness and the slowness and the changes in balance that comes related to that. So for those folks, we recommend trying levodopa or trying physical therapy, which I will say always helps. So I would definitely, I can't stress enough how important physical therapy can be. Some patients, though, have ataxia. And then the ataxia, if you recall from that video from before, is that incoordination that is secondary to dysfunction of the cerebellum. Unfortunately, there are no medications to treat ataxia, so we rely heavily on the benefit that can be provided by physical therapy. Sometimes patients can't walk or have trouble walking and falling because they have orthopedic changes. They have arthritis of the back, the hip, the knees, Sometimes these knees, for example, need to be replaced, and we would send them to our orthopedists colleagues to have that fixed. But sometimes patients are not eligible for surgery, and sometimes just managing pain can be good enough, especially back pain. Sometimes patients undergo steroid injections or lidocaine injections to the lower back, and just by relieving the pain, they feel like they can walk better. Sometimes patients are just deconditioned. They just sit at home and don't exercise as much as we would like them to. And then, of course, the muscles start to get weak. So again, physical therapy there in general, exercise is the way to go. But then the last one that I want to mention is the eyes. If people have trouble with eyesight, which again, eyesight is not a change that you would see in MSA, like it doesn't really affect your eyes. However, oftentimes patients with MSA, because of their age, can have other conditions like cataracts, for example. And if you can't see where you're going and your balance is already not great, of course, you're going to fall. So things like the cataracts, for example, we try to fix whenever we can, because people do really feel like these surgeries where they take the cataracts out can be life-changing and can lead to much more steadier gait. Now let's talk a little bit about the non-motor symptoms of MSA. So as I mentioned before, orthostatic hypotension is very common in these patients. And orthostatic hypotension really relates to a drop in blood pressure upon standing. It doesn't have to happen immediately. Sometimes patients noted that the blood pressure drops a minute or two after they've been standing up. So it can be tricky sometimes to diagnose. Patients sometimes, we ask them to take their blood pressure sitting and standing at home. And they don't really notice a change because they check the blood pressure as soon as they stand up. So something I would recommend would be to wait at least a minute before you check the blood pressure standing. And if you see a drop there of more than 20 points in your top number, your systolic blood pressure, then that highly suggests orthostatic hypotension. This can be problematic. Patients who drop their blood pressure when they stand, they feel lightheaded. They often can pass out or near pass out, and definitely this leads to fall. So we're aggressive treating this condition. There's a number of different medications. There's 4 of them approved in the US for the treatment of low blood pressure: Mestinon, Midodrine, Florinef, and Northera. All of them have generics except the Northera. So Northera is the most expensive of all of these 4. And they are all 3 times a day drugs except the fluorocortisone. The fluorocortisone is the only one that is a once a day medication. There's pros and cons to taking once a day meds versus 3 times a day meds. But oftentimes patients take a combination of these. And what we try to do is try to mix and match mechanisms of action so that they can improve their blood pressure in different ways. Urinary incontinence can also happen in patients with MSA. Pelvic floor therapy, believe it or not, can actually be quite helpful to strengthen those pelvic muscles. Occupational therapists are usually trained in pelvic floor therapy. Bathroom breaks, scheduling bathroom breaks, particularly if you're going to go out, that can also be very helpful. Some patients need to catheterize. Some patients catheterize intermittently. Some patients have a permanent indwelling catheter, which can be a little uncomfortable, but can be a lifesaver particularly when having to go out or having to have a sort of activity where a scheduled bathroom break would be tricky. You can catheterize before that and really make sure that the bladder has been emptied, and it'll give you a few more minutes to hours of relief. When these physical measures are insufficient, then of course there's medication for overactive bladder and incontinence. We very much like Miravigron or Mirbitric because it is the only incontinence medication that doesn't cause confusion. All of the others can do it, so we tend to shy away from them if we can. Mirbitric, unfortunately, also is not generic and it's a little bit pricey, but I would say most insurances do tend to cover it. Now, this is REM sleep behavior disorder. I have another video here. I hope you can see it. REM sleep behavior disorder happens when patients start acting out their dreams. You can see a video here of a gentleman who was in deep sleep, and then all of a sudden he starts punching when he's acting out a dream. It can be really problematic. Patients can hurt themselves when they start acting out their dreams very violently. They can also harm their sleeping partners. So we tend to treat it. REM sleep behavior disorder can be present years or even decades at times before the onset of Parkinson's symptoms. And it's a predictor of conversion to one of these conditions. Sometimes we follow patients over time who have REM sleep behavior disorder, but not much else. About 40% of them will convert to some sort of Parkinson's syndrome within 5 years, and about 80% of them will convert in 10 years. To treat it, we use melatonin, which is an over-the-counter supplement. That can be very helpful. When that fails, we rely on clonazepam, which is not over-the-counter. That is a prescription drug. Here are other measures that can help with sleep behavior disorders. If patients are jumping out of bed, we tell them to move the bed towards a wall or to invest in a bed rail, as you can see here. A body pillow between the patient and the patient's sleep partner can also be helpful. Then if the patient is punching at night, they'll punch the pillow and hopefully not the bed partner. So these are kind of simple measures that can be taken also to treat this condition. Insomnia is very common, particularly fragmented sleep, where people keep waking up in the middle of the night. Just to have a heads up here, the amount of hours that patients sleep, or not patients, but people in general sleep, does change over time. As you can see in this graph here, newborns sleep anywhere from 14 to 17 hours per day. But as you grow up and as you become older, as you can see in the other side of the spectrum, patients older than 65 really only need 7 or 8 hours of sleep in general, or in average, I would say. But some patients need as little as 5 hours and they feel okay, and that's okay. Oftentimes my patients tell me like, well, I only am getting 5 hours of sleep at night. And I want to sleep more because I used to sleep more. And then when they tell me this, I ask them, well, do you feel tired in the day? And they tell me they don't. They just wish that they could sleep more. And it could just be that 5 or 6 hours is the normal sleeping time for you. So as long as patients can function during the daytime and don't have daytime sleepiness, we don't necessarily have patients sleep longer than their body normally wants them to. That being said, as I said before, patients with MSA do have sleep fragmentation. They keep waking up. The bladder is a big culprit there. But sometimes patients just wake up for no reason. Sometimes they have trouble turning in bed and that wakes them up. Sometimes they're just light sleepers. They can also wake up early, and that goes back to what I was saying before, that people don't really need as much hours of sleep anymore. So if you go to bed at 8 p.m. and you only need 5 hours, that means you're going to be up at 1. And in those cases, I just try to tell patients to try to stay up as late as they can, just so that they will wake up a little later. Reversal of the sleep-wake cycle can be really hard to treat. Patients that sleep during the day and are up at night, I would say limiting naps during the day can be helpful. Sometimes we rely on using stimulants in the day and sleeping medications at night, which can help, but of course, we're adding more pills, which we try not to do unless we have to. And then sleep apnea. I think sleep apnea is an important one here, especially patients who are overweight or obese have a higher risk of having sleep apnea. Sleep apnea is very common. Patients take these really loud snores and deep breaths when they sleep, and then they hold the inspiration for a few seconds and then they let it go. It can have a lot of complications. Patients with sleep apnea have a higher risk of stroke and heart attack. So we try to diagnose it whenever we can, and a sleep study is the way to diagnose that. Oftentimes, though, you'll get clues from the sleep partner who will tell you that a patient is a very loud snorer, and they will probably also describe to you the apneic spells. To treat insomnia, this is what we do. Exercise during the daytime, multiple benefits from exercising. This is one of them. Melatonin, which, as I mentioned before, we use for the REM sleep behavior disorder. We also can use for sleep. I like the extended release version of melatonin. It keeps people asleep, whereas I find that the immediate release helps people go to sleep. It doesn't necessarily keep them asleep. Gabapentin can help with fragmented sleep. It also helps with pain, so we like that one. Trazodone is a good one. It also helps with mood. Clonazepam, as I mentioned before, is a prescription drug that helps mostly just with sleep and anxiety. Ambien, I don't like very much. That's zolpidem. Patients can sleepwalk on Ambien, so I don't really like to use that drug, but it is an option too. Now, depression and anxiety are very common in all patients with Parkinsonian syndromes, and MSA is not an exception there. It's a spectrum. Depression refers to this sort of overwhelming feeling of sadness, whereas anxiety is really just feeling more like on edge or just really nervous or jittery. But they can coexist, and oftentimes they do. There can also be symptoms that sort of are in the middle of this Venn diagram here that kind of fall under both categories. And then we usually treat depression and anxiety as a unit. So sometimes patients have one or the other, but oftentimes patients have both, and we treat them both the same. And many of the medications treat both too, fortunately. So oftentimes we can kill two birds with one stone. Here's what we do for depression and anxiety. Non-pharmacologic interventions like exercise, yoga, biofeedback can be very helpful for anxiety. Benzodiazepines is a group of medications that are very good for anxiety. Clonazepam, this is the third time I'm mentioning it, as you can see, has many indications. This one being another one. Clonazepam is a long-acting anti-anxiety drug, which we like to use more than the short-acting. The short-acting anti-anxiety drugs really just work for 1 or 2 hours, and then the anxiety comes right back. So we like to use clonazepam, which usually works for about 5 or 6 hours at a time. The antidepressants can also have anti-anxiety effects. As you can see here, there's a number of different ones. Lexapro or escitalopram, we usually like very much. Some people feel like it doesn't make them sleepy, it doesn't make them tired or foggy, it's well tolerated. When people have a lot of anxiety, Lexapro can help, but also sertraline. So those are both for depression and anxiety. A lot of patients have fatigue, and for those folks, we recommend Effexor or venlafaxine, which is a little bit of an energizing antidepressant. Some patients have trouble sleeping, and then trazodone and Cymbalta or duloxetine help with those. And some patients also have pain, and for those folks, we recommend duloxetine and amitriptyline. So as you can see, many of these antidepressants have additional properties. So depending on which symptoms the patients describe, we select one versus the other. For patients at Penn, we also have a counseling program. It is run by our very talented social workers and psychologists. It is free to our patients. The phone number is there. Basically, the way it works is you call that number, you leave a voicemail, they call you back for an appointment. Unfortunately, it is not a resource that's available for patients who are not patients of ours at Penn. Constipation, very common also in patients with MSA. Exercise can help, just mobilizing the gut can really be helpful. Hydration, a lot of our patients have trouble staying well hydrated, particularly in the summer months where the heat dehydrates you. So we very much encourage the use of lots and lots of water or any really liquid that you like to drink. Fiber and having like a high fiber diet can be very helpful. There's also medications. Stool softeners are often available over the counter. That's the case here of Colace. Senna is another one that can be helpful. So the Senna makes you go, whereas Colace just makes it easy to go. So it's a little bit of a different mechanism of action there. And then Miralax, we like very much. Miralax pulls water into the gut and it helps people go. So any of these or combinations of these can be helpful to treat constipation. Now, loss of sense of smell. A lot of our patients tell me like, well, what if I lost my sense of smell? Like what's the big deal? Well, it's actually a big deal because if you don't smell, then you don't smell your food. And if you don't smell your food, you lose your appetite. And then if you lose your appetite, you lose weight. And weight loss is something that we very much try to fight in patients with MSA. Unfortunately, we have no way of bringing your smell back if you've lost it, but we do encourage high spicy, high flavor foods. There's 3 examples here, Indian, Mexican, and Thai, all of which are really strong flavors. Now, even though patients might lose their sense of smell, they have not lost their sense of taste. So the tongue still is able to detect these tastes. And eating foods that are less bland and more flavorful sometimes does the trick. So I highly recommend trying that if you're into any of these ethnic foods. Fatigue, very difficult to treat. The disease itself causes it, but also when people don't sleep well, they can feel fatigue. So the first step when managing fatigue is making sure that people don't nap during the day and really use the bed only for sleep. Watching TV or reading or eating in bed, probably not the best ideas. Exercise can also help. It tires you out, so then you go to sleep. Sometimes treating the motor symptoms actually helps the fatigue. Sometimes the fatigue is just a sign or maybe not a sign, a symptom of low dopamine. And sometimes all they need is a little bit of dopamine. Caffeine can be very helpful. I usually tell my patients to drink 2 to 3 cups a day if they like coffee. And then if you want to try a medication, we can use one of these stimulants. There's a number of them listed here. I like Ritalin, as though I would say that's my first one to go to. When Ritalin doesn't work, I try probably Provigil next. However, stimulants can affect your heart. So patients who have heart disease, probably not the best candidates for Ritalin. And there is a potential for abuse and dependence. So it's a highly restricted substance. The pharmacy does not allow refills. So patients who take these medications need to call in their refills every month. Drooling can also happen in patients with MSA. The mechanism of drooling is one, patients don't swallow as much, so the saliva tends to stay in the mouth. And then two, patients with MSA don't close their mouth as much. The lips tend to be parted at least some part of the time. So if your mouth is open and you have a mouth full of saliva, the saliva is going to come out. There's different ways of treating it. There are these drops that are called atropine drops. They're eye drops actually, but we use them under the tongue, and it usually dries up your mouth for about 12 hours. It's a prescription medication, so you would have to ask your doctor for a prescription for this. But it usually works. It does have a little bit of a bitter taste, but if you can stomach it, it's actually highly effective. There's also these patches called scopolamine patches. Those are placed behind the ear every 72 hours. I don't use them very much because they can cause confusion, so it's not my favorite agent to use, but it is a possibility too. And then sometimes treating the Parkinson's side of things with Parkinson's medication can also help with the drooling. People start swallowing more so the saliva doesn't pool in the mouth. Botulinum toxin injections or Botox can also be very helpful. We inject the salivary glands. You can see 2 schematics here of where the salivary glands are. We tend to inject mostly the parotid glands, which are the ones here in the cheeks. They're very easy to do. It takes 5 minutes in the office and it works for about 3 months. So it's another treatment that can be very helpful. All right, now let's talk about multidisciplinary care at Penn. The Movement Disorder Center at Penn is a very old center. It was founded in 1982. So we're going on 40 years, I guess, now of the center being in existence. And it was founded by Drs. Matt Stern and Howard Herdick, who you can see in the picture here. We're located in 9th and Pine in Philadelphia, and it's a very large group. You can see here the stats of how many people are in our group. Within our center, we run the COPE Clinic, and the COPE Clinic is the special clinic for the multidisciplinary care of patients with atypical Parkinsonian syndromes, including MSA. This is the way the COPE Clinic works. It's run by a nurse coordinator, and there's different teams. There's the medical team, the therapy team, social work, and research. Within the medical team, I'm one of the specialists who see patients here, but we also have a cognitive neurologist whenever there's cognitive issues in our patients, and a palliative care physician. Within the paratherapy team, we have the physical, occupational, and speech therapists. And we all see the patients on one day. So it's a little bit of a long day. It's about 4 hours, but everybody comes in and sees patients for 30 minutes each. And at the end of the day, patients receive input from all of these different teams. So we think it's certainly an activity that is worthwhile. Most of our patients are very happy with this level of care. And oftentimes patients who come to the COPE Clinic come every 6 to 12 months. So we do highly believe in this multidisciplinary model as a much more efficient and effective, really, way of managing MSA. This is what a typical day looks like. Patients come in. They, in the era before COVID, all of these appointments were done in person, but now we're doing a hybrid model. At the height of COVID, we went 100% virtual. And then now that the numbers are better, we're doing mostly in person with some virtual. There's an app that we use called the Blue Jeans app, and people log in there and we can see them in their house. Then, as I mentioned before, every team has about 25 to 30 minutes with the patient. And then at the end, we all get together and discuss all the cases, after which our nurse coordinator sends a summary to all of the patients who came to see us on a given day. So you receive sort of a report of what everybody had to say and what all of our recommendations are. We get referrals from different places. Most of our patients come from our own clinic, but we also get regional referrals from the tri-state area. Hopefully, in the future, we would get a much broader referral base, but the truth is multidisciplinary clinics like this are sort of popping up around the nation. So hopefully we won't need to have such referrals from such faraway places, and people can find this care in a more local fashion. Sometimes we refer patients to other doctors ourselves. Cardiologists is a big one, gastroenterologists and neurologists, I would say. Those are the three main ones. Sometimes patients refer or describe a lot of anxiety and depression. We have a psychiatrist. We actually have two psychiatrists who specialize in the treatment of depression and anxiety in patients with Parkinsonian syndrome. So we usually do those internal referrals. And then sometimes patients have vertigo that is sort of unrelated, but definitely impacting gait. So we will refer them for vestibular therapy. Now, the last part of the talk will focus on clinical trials. Just so we have some definitions clear. If we think about medical research, there's three types of medical research. There's basic science research. That's the type of research that happens in the labs, and it can be on a petri dish or on monkeys or mice. Then there's translational research, where findings in the lab are then brought to the patient or vice versa. You discover something in a patient and then you go back to the lab to prove it. And then there's clinical research, and that's the one we'll focus on today, which is basically research that is focused 100% on humans. Clinical research can be of two types. You can have observational studies, which basically you just follow the population over time to see how a disease behaves over time. Or you can have interventional studies, where you actually do an intervention of some sort to try to find a result. That's where clinical trials fall. Clinical trials are interventional studies, and basically the intervention can be a drug or can be an intervention like exercise, for example. So it can be a physical intervention. It could really be anything that you are putting into a population and seeing how that population behaves after you've done the intervention. In general, clinical trials are blinded, meaning that to avoid biases, neither the patient who is in the study nor the study coordinator or the primary investigator know which type of intervention is being submitted. So this goes back to, you probably heard this idea of the placebo. The placebo is basically that blinding, right? You give patients a study drug, but you don't know if the patient is on drug or placebo, and neither do we. And that's part of the blind part of the study. Some studies are unblinded, but the quality of the data that comes from unblinded studies is not as good as people who have, or studies that are blinded. The studies can also be controlled when you have two groups of people, one group in which you do the intervention and the other one in which you do not. That's called a controlled study. An open label study is one where you do not have a control group. Everybody in your group or in your study receives the intervention. And again, here, the control groups or the control studies are much more telling than the uncontrolled or open label studies. And then randomization. So randomization means that when a patient comes in, you don't put them in a group. You don't say like, okay, you are going to be in the control group and you are going to be in the study group. You really leave it up to chance. And we do that to try to minimize biases. So having had these sort of definitions in mind, what we think about when we think of the drug development process, if we think of a multi-step process, it starts in the lab. So it starts with that basic science research that I mentioned before, where scientists discover a compound, let's say, that works in animals. So the decision is made to now treat it in humans to see whether humans get that same benefit that animals do. So then we go to a phase 1 study. A phase 1 study is when you take that compound and you try it in a small group of people, usually healthy people, not necessarily people who have a disease. And all you're looking for is side effects. If you realize after a phase 1 study that a drug doesn't have really terrible side effects, then you can move to phase 2. In phase 2, you now try the drug in a larger group of people. The group of people might actually be people who have the disease that you're trying to treat. And then you're also trying to figure out what's the actual dose that people need. How much is too many, or how much is too much, and how much is too little of that study medication that you're investigating. If a phase 2 study is successful, then you now move to a phase 3 study, which is a much larger study. And here you're also looking at safety, but you're also for the first time looking at efficacy, meaning does the drug work? And you design the trial so that you can measure whether your intervention actually is successful. If a drug passes phase 3, then the FDA can approve it and the drug hits the market. But one thing is to use a drug that has been used in thousands of people, and another very different one is to use a drug in millions of people. So when the drug hits the market, it really can be purchased by millions of people, if not billions of people. And sometimes when you follow billions of people over time, side effects come out that you weren't really able to pick up in the previous versions of the trial. So that's what's called a phase 4 study. It's a post-marketing study. The drug is already out in the market, and you're just looking out to see whether in the community, people describe side effects that were not available before. Now, phase 4 studies are actually very important because if a phase 4 study shows a very serious side effect that we didn't really pick up on the previous phases, drugs can come off the market, and they have. The FDA over the years has taken off a number of drugs off the market because even though they passed phase 1, 2, and 3, it was during that phase 4 that we really figured out that there was something really wrong with this drug, that it shouldn't really be available to the public. Now, as you can see, the development of drugs is a very long process. And the only way of getting new drugs in the market is to participate in clinical trials. So I can't really encourage you enough. If you have interest in participating, please do. It might help you, but it will also help the larger MSA community. Sometimes it also will allow you, let's say you're in a clinical trial and the drug that you're trying works, then you may have had access to the drug sooner than you would had you waited for the drug to come out to the market. In addition, because you're in a clinical trial, you're being constantly monitored by doctors. So it's a way of getting extra care actually for free that you wouldn't otherwise have access to. And then participating in one trial doesn't mean you cannot participate in other. You cannot participate in 2 trials at the same time. And you can imagine that that would probably be not a good idea to do because if something works, you won't know which of the 2 drugs did it. But oftentimes patients can participate in one trial, and then after a few weeks or months, you can participate in another. So if you've participated in a trial before, that doesn't mean that you cannot participate again in the future. Now, there is this website called clinicaltrials.gov. Some of you might be familiar with this website. For those of you who have never heard of it, I encourage you to check it out. It is run by the federal government, and all of the clinical trials in the nation, if not the world, are registered here. And basically, it works like a search engine, just like Google. You type in the name of the condition that you're trying to look for, and then you can select, as you can see, the area that you're looking for. So I did the experiment the other day, and I wrote multiple systems atrophy in Philadelphia, and I wrote a 50-mile radius to give me an idea of all of the studies that either are recruiting in the area or have been recently finished. And here's what I found. There's a number of them that showed up, and I'll just mention the ones that perhaps are relevant. This is a study that finished. This was a phase 2 study. So again, that safety study in a little bit of a larger group than the phase 1, looking at this compound called rasagiline. Rasagiline is a drug that we use in the treatment of Parkinson's disease. It slows down the breakdown of dopamine in the brain, and it was tested to see whether patients with MSA would benefit from the use of rasagiline. Unfortunately, the study was negative, and it is not recommended that patients with MSA at this point go on rasagiline. Here's another study. This is looking at a drug called ampreloxetine. It was a study looking at the use of ampreloxetine for the management of orthostatic hypotension. As you recall from previous slides, there are 4 commercially available drugs for the treatment of orthostatic hypotension and MSA, and this was supposed to be the 5th one. Unfortunately, as you can see from this press release that the company came out with in September of 2021, the study did not meet its primary endpoint and is no longer being developed for this purpose. Here's another study that you might have heard about. This is the Biohaven trial. The drug here is called berdiperstat. We actually were a site for this study at Penn. This was a phase 3 study of a drug that was supposed to slow down the progression of the disease in multiple systems atrophy by working as a powerful anti-inflammatory drug. Unfortunately, as well, there was a press release here from September also 2021 showing that berdiperstat did not meet its endpoint, and it is also no longer being developed for the treatment of MSA. Which brings me to this. So this is the latest and greatest. This is a new study that we are a site at Penn. It is from a company called Lundbeck, which is a Danish company that's been around for a few decades. And it is a drug that is supposed to slow down the progression of multiple systems atrophy. The way it works is, if you remember one of the first slides that I spoke about, there is this protein that builds up in patients with MSA called alpha-synuclein. This medication is supposed to get rid of that protein that is building up. And by getting rid of that protein, we hope that it will alter the course of the disease. We don't know whether this is going to work or not, but we are looking into it. It's a placebo-controlled trial, meaning you might get the drug or you might get a placebo. But the randomization there is 2-to-1, meaning out of 100 people, 66 are going to get drug and 33 are going to get placebo. It's an infusion trial, so it's not a drug that's given by mouth. Patients need to come in once a month and get this drug through the vein, basically, at the infusion center at Penn. There's a number of different sites in the country, and we are one of them. We are about 2 to 3 weeks of being activated, so we're very excited and definitely looking forward to participating in this. Again, we don't really know if this is going to work, but certainly excited about the mechanism of action of this compound. Here are the inclusion and exclusion criteria. So patients have to have possible or probable MSA, and they're taking both patients with MSA P and C. The onset of symptoms has to be within 5 years of diagnosis. There is this scale called the UMSAR scale, which is a scale that looks at the severity of disease. It has to have a score of less than 16 in part 1. There has to be a MoCA. So a MoCA is a cognitive assessment with a score of more than 22. Normal is 26. So they do allow a slight degree of cognitive impairment within this study. And then the exclusion criteria, you cannot be treated with a similar drug in the last 12 months. But as I said, these drugs are experimental, so the chances of being treated with a similar drug are quite slim. They're not looking at patients who have a family history of MSA or any other explanation for the symptoms that is not MSA. So patients who have other conditions that look like MSA, but it's not MSA, then those folks are not candidate. You can imagine that this company really wants to make sure that they recruit the right type of patients. The age here is 40 to 75, and they're taking both men and women. If you're interested in learning about our trial, this is our name of our research coordinator, Ellen Indick. Her email is ellen.indick@pennmedicine.upenn.edu. I think you guys have the slides, so you can always go back and look at the email if this is something that you would like to learn more about. Now, to close, I will say that, as you remember, Parkinsonism is this spectrum term, which really refers to anybody who has symptoms of Parkinson's disease. The hallmark of MSA is the presence of these Parkinson's symptoms, along with changes in the autonomic nervous system. It's a clinical diagnosis. We don't, unfortunately, at this point, have a blood test to say that somebody has MSA. And then something that's important to keep in mind is that it's okay if the diagnosis is not 100% certain, because the management is the same. There is no specific treatment per se for patients with MSA that you are, quote unquote, missing out because you were told that you had Parkinson's. The treatment is exactly the same. So it doesn't really matter. And as I mentioned before, it's hard sometimes to know whether somebody has MSA versus Parkinson's, particularly at the beginning. But I'll finish by putting in a plug again that I think the way to have very much tailored medications for the treatment of MSA is to participate in clinical trials, and that will allow us to develop these medications and hopefully have much more effective treatments in the future. So I want to thank you for your attention, and I'm going to finish here. I'll stop sharing my screen. And then I will turn on my camera and happy to answer any questions you may have.
Good morning. Thank you, Dr. Deik. Again, I appreciate you rising to our technology challenges this morning.
Sure.
The best laid plans. So I hope everyone enjoyed the session, and Dr. Deik is going to stick around for a while and take some questions from the group. So we do have a few already here. If anyone has questions, feel free to type them out. There's a Q&A section in the Zoom meet, so please feel free to go ahead and type out questions. We do have a question asking what your thoughts are on the SIN1 skin biopsy test.
Yeah, so the SIN1, for those of you who haven't heard about this, is a new technology that is FDA approved. And it's basically a skin biopsy where they look at the nerves within the skin to see whether there is presence of alpha-synuclein. So the benefit, I think, of the SIN1 test is when it's unclear whether somebody has a Parkinsonian syndrome or not. So if the question is whether there is any sort of Parkinson's, then yes, I think this can be very helpful. However, if it is clear that somebody has some form of Parkinson's, I'm not sure that it's very helpful to do a test. It would be a confirmatory test, I suppose. But oftentimes we don't really need that confirmation because the symptoms are very evident. So I think there are cases in which it can be helpful, but I wouldn't say that everybody should have this. I don't think it's necessary for everybody.
Thank you for that. Someone is asking if restless leg restless leg a symptom of MSA.
So as RLS can be seen in patients with Parkinsonian syndromes, oftentimes we see it more in patients with Parkinson's disease, but it can be an MSA. Interestingly, it's thought that the mechanism of restless leg syndrome is the loss of dopamine. So the same loss of dopamine that gives patients Parkinson's symptoms has also been associated with the onset of RLS. Patients who have RLS but don't have Parkinson's don't have loss of the cells that produce dopamine, more the way that the brain uses the dopamine that leads in this sort of functional deficit, if you may. And the treatment for those patients is the same medications that we use to treat Parkinson's. So to sort of in short, yes, we can see RLS as part of MSA, but I will say that we see it much more in Parkinson's than we do it in MSA.
Do healthy people have alpha-synuclein?
That's a great question. The answer is yes. So everybody, we all have alpha-synuclein. Alpha-synuclein is a protein that normally has function in our brains. So it helps with the transmission of signals between brain cells, as well as in the metabolism of the brain cell. The problem is not having alpha-synuclein. The problem is when the alpha-synuclein starts to clump up and clog the cell in a way. So it's a normal protein that everybody has, but in patients with MSA, for whatever reason, and again, the reasons behind this are not fully understood, it's the accumulation of the protein that leads to the problem.
Okay. The next question, what about the agent ATH434 alterity? Where is it being done?
Can't say that I'm familiar with that. I'll look it up. I don't know what that compound is.
Okay. Let's see what else we have here. I'm sorry, my screen is not cooperating. Have you heard of psilocin, the non-hallucinogenic form of cyclobin for the treatment of Parkinson's disease?
Yeah, so this is a hot topic of research. Now they're using, these are like the magic mushroom compounds. derivatives of hallucinogenic mushroom for the treatment of refractory depression. There are studies ongoing for patients with very severe depression with the use of these drugs. To my knowledge, it is not being used in Parkinson's disease. I can't say that I'm familiar with this application, but I can see how a clinical trial would make sense.
Okay. We have a 77-year-old patient, 8 years after MSA diagnosis. Would Ellen be able to find out if she may be approved for the forthcoming trial?
Yes. So the onset is usually 5 years, so 8 years might be a little bit of a stretch, but we're happy to look into seeing whether there is any way that can happen. I'm not sure that will be possible though, because I think they're strict on the 5-year rule.
Okay. Is orthostatic hypotension always present? We have a patient with many other symptoms, movement, urinary, digestive, etc., but does not seem to have blood pressure issues that have been noticed.
It doesn't have to be present. It's very common. Most people do have it, but it doesn't have to always happen. I will say as the disease moves along, it does turn to come up if it hasn't before, but it doesn't have to absolutely happen.
Okay. Are muscular pain and burning during and after sleep common with MSA?
What happens oftentimes, and this is true not only for MSA, but also we see it in patients with Parkinson's, is that during sleep, they don't move very much, and the muscles tend to feel kind of tight, and then they wake up the next day and they just feel stiff. In patients with Parkinson's disease, and I suppose also in patients with MSA who respond to levodopa, the symptoms improve the moment that the medication is taken, but a lot of patients do describe feeling just achy and sort of sore and stiff when they wake up in the morning.
What is some management for that?
So sometimes we tell patients to take medication in the middle of the night. So some of our patients wake up in the middle of the night to go to the bathroom, and we tell them to take a dose of Cinemet so that by the time they wake up the next day, they don't feel as stiff. Muscle relaxants can also help.
Okay, thank you. What about your thoughts on stem cell research? I know that's a big topic as well.
Yeah, it's a hot topic. A few lines of research currently undergoing with this. Stem cell research right now in the US at least is limited to Parkinson's disease. I'm not familiar, or I'm not aware, I would say, of any stem cell trials looking at patients with MSA. The premise of it is promising, but the studies that have been done so far have not been positive. So I guess we'll have to wait and see whether one of the trials that are currently ongoing turns out to be positive or not.
Okay. Is there a specific MRI for MSA?
So the MRI is the same. It's a brain MRI without contrast. It's usually what we order. The changes in the MRI, though, are the ones that I mentioned before: the Hotchkiss-Bunch sign, the atrophy of the cerebellum, and then signal changes within the basal ganglia.
Okay. How far are we from a treatment that will slow down MSA?
That's a great question. So, science is not linear. So you don't necessarily build up slowly towards a treatment. You are like this and you try different things and they either work or not. And then all of a sudden one of your studies work and then you spike. So it's not a linear trajectory. I think the moment one of these compounds actually works, then the landscape will change overnight. So to answer the question, it could be tomorrow or it could be in 5 years. It's hard to say.
So much about this disease is hard to say. And I think that's, a lot of the frustration in this community.
Absolutely.
Okay. We have another question asking if alpha, I'm sorry, I'm wearing the wrong glasses. So I'm having trouble reading.
I think it's alpha-synuclein, a misfolded protein.
Yes, that's exactly what it says. And if you'll bear while you're answering, I'm going to change my glasses.
Sure. So it's a protein that can misfold. And as it misfolds, it accumulates, and it's thought that the accumulation is due to the misfolding of the protein. It's the same situation that happens in Parkinson's disease. It's the misfolded version of the alpha-synuclein that we think leads to disease.
Okay, are headaches and cognitive issues common for MSA?
No, neither of them are common findings. In fact, I think one of the good things about MSA is that there's less likelihood to develop dementia compared to Parkinson's disease. So one of the things that are usually spared is the thought process.
Will exceptions be considered when score is 21 versus 16 for the trial?
No, unfortunately, no exceptions.
Okay. Are psychological issues commonly present along with anxiety? We have someone that has some paranoia issues as well.
Yes, it can be. And paranoia can be part of the disease, but can also be caused by the medications that we use. So dopamine agonist medications like ropinirole, pramipexole, or rotigotine, Nupro, are very sort of strong drugs that can cause paranoia. Sometimes the stimulants that we use, the Ritalin that I mentioned before, can also cause paranoia. And sometimes the disease itself. So it can be sort of a double whammy there where the disease causes the paranoia. And then on top of that, you're taking medication that causes paranoia. There is medication for it, though. If patients are unable to come off the drugs that are causing it, there are anti-paranoia medications that can be prescribed.
Okay. Will you be using the newly announced ACI 12589 live PET images differentiating between MSA and Parkinson's?
I don't believe we have that capability at Penn yet, but perhaps in the next few months.
Okay. And then I think there was a follow-up on the alpha nucleotide being a misfolded protein and if it's related to the amino acid sequence.
Yeah, so the amino acid sequence determines the structure of the protein. The tertiary and quaternary structure of a protein is determined by the different amino acids that are present within the protein. And sometimes proteins can have different structures, even though the amino acid sequence is the same. So there's not necessarily a mutation in the alpha-synuclein. Like it's the same protein still, but it turns out that the protein can be stable in different conformations. And one of these conformations favors aggregation, whereas the other one does not. So it's this switch that happens, unclear why, from the non-aggregated to the aggregated that sort of brings on this cascade effect where the misfolded protein itself causes other forms of alpha-synuclein to misfold as well.
Okay, we have a couple of other questions in our chat. How do you differentiate between PAF and MSA when you diagnose someone?
That's a great question. It can be very difficult to differentiate clinically, patients with PAF. So PAF, for those who don't know, stands for primary autonomic failure, which is a condition where the autonomic system is compromised just like it is in MSA, but there are no signs of Parkinson's. So besides the autonomic system being not working well, you can really not make a diagnosis of MSA if you don't have either symptoms of involvement of the basal ganglia or the cerebellum. PAF has a better prognosis than MSA, but clinically it can be difficult to differentiate 100%. Sometimes patients have subtle symptoms of Parkinson's, so you had to just follow them over time to know whether somebody has one versus the other. Sometimes patients who we diagnose as PAF down the line, either months or years later, end up converting to either MSA or another Parkinsonian syndrome. So sometimes we use a DAT scan. A DAT scan is called a dopamine transporter scan, and it's a scan that can help differentiate between having some form of Parkinson's and not. Now, there are reports that people with PAF can also have positive DAT scans. So if you have a positive result, it doesn't really help you. But if you have a negative result, I think it can help you. And it probably predicts that those patients with PAF will probably not convert to some form of Parkinsonism. Now, whether that is true or not is still an area of research, and we still follow them over time just to make sure that that conversion doesn't happen.
Is involuntary jerking a symptom of MSA at times triggered by anxiety?
Yes, so people can have something called myoclonus. So if you remember that video I showed you, the woman with the little twitchy fingers, that's called polymini myoclonus. A larger version of that is called myoclonus, which is sort of a whole body jerk. It can be a limb or it can be the trunk. And we do see that in people with MSA.
Okay, and this appears to be our last question. If accepted in the trial and live out of state, do we need to travel to Penn each month for the injection?
Yes. So the trial is based at Penn, and the experimental compound is at Penn, but the study will reimburse, will give you a stipend actually for transportation costs.
Okay, well, thank you. It looks like, oh, we got one more. Is life expectancy for PAF longer than for MSA?
Yes, so the life expectancy of PAF is around 10 to 20 years.
Okay, that looks like that's everything on the Q&A. Dr. Deik, thank you very much. This has been a great presentation. I think everybody really got a lot out of it. Do you have any final thoughts that you'd like to share before we wrap up and talk about the next couple of events MSANJ has planned?
Yeah, no, thank you so much for having me. This has been fun. I think I'll just leave with the plug that I think participation in research is the key here. I share your pain and your frustration. You know, this is what I do every day. I see patients with MSA and other atypical Parkinsonian syndromes every day, and the concern and the complaint is the same. Why do we have a drug that works? Believe me, it's not for the lack of trying, but we have to keep trying. And the only way we can try is if we really partner with you all. So I highly encourage you to participate in any kind of research study that you feel like will be a fit for you. More and more new research studies are coming out, so definitely check that page out, clinicaltrials.gov, periodically, and see if new trials pop up in your area that you would like to participate in.
Well, thank you very much. And again, I appreciate you being a good sport, jumping on live and working with us, and for taking your time with us today to give this talk. Anytime you want to come back, you know, you're always welcome. So thank you again. Okay, just a couple of little last minute things I want to go over. Another webinar coming up next. It's the Parkinson's Project, Sing with Intent. That is coming up next Saturday at 11 a.m. Oh, there it is. See, technology. And then we also have our April support group coming up on the 9th. And our board member, Victoria Pena Cardinale, will be facilitating that session as well. So please, if you're interested in next week's session, go to the MSANJ website to events and register for that. That would be a different registration from today's session. And if anyone is interested in attending the support group on April 9th, please shoot an email over to that contact@msanj.org. All are welcome. So again, thank you everyone for coming out to this webinar today. Thank you, Dr. Deik. And we look forward to future interactions with you. Have a wonderful weekend. Take care.